Welcome to a one-hour Pallium Project archival podcast of a professional development event. The views presented in this session are those of our expert guests and participants from across Canada. In this podcast, Jackie Peaton, an advanced practice nurse in hospice palliative care, moderates a panel discussion with Aboriginal Relations Consultant and President of the Aboriginal Nurses Association of Canada, Gaye Hanson, and Adrienne Wiebe, Coordinator of Multicultural Services for the Royal Alexandra Hospital in Edmonton. This session was called Building Cultural Competence, an Aboriginal and Multicultural Perspective.
Gaye, can you tell me, what does it mean to be culturally competent?
Thank you, Jackie. First, I think just to talk about Aboriginal people being the Indigenous or First Peoples of Canada, and in this terminology we're talking about First Nation, Métis and Inuit people of Canada, and the multicultural communities are individuals and families from outside of Canada. So as much as we're pulling these two communities together in this presentation, I think it's important to distinguish as well as create bridges in certain areas of competence. And it's also important to distinguish between the two in terms of their historical and current experience and also their sociocultural realities. So when we're talking about cultural competence, in my mind, it's the step beyond cultural awareness, that we can go through all kinds of experience and educational programming to develop an awareness of other cultural groups and some of the diversities that they deal with. And competence is a collectivity of skills, abilities, capabilities, competencies that an individual puts together in order to build high-quality relationships and care relationships with families from different cultural backgrounds. And that competence is highly contextual, that it may well be different in one community or one care setting compared to another, and certainly responds to the diversity within a particular cultural group. That competency would allow you to assess where an individual or family reside within the broader context of that particular cultural group and respond accordingly.
Adrienne, do you have anything to add to that definition?
I think Gaye has really covered that well. The only pieces, of course, there's a lot more to discuss related to this, but the only pieces I think we need to remember as well are that since culture is not static, this isn't something you can pin down and then you have it figured out. It's constantly changing, and that's part of the complexity of what we deal with, so that intergenerational change or change as people interact with other cultures or mainstream culture is constantly occurring. And the other piece that I think is really important for all of us to remember is the grounding for having a culturally competent practice is self-awareness. So understanding your own cultural background and your values, where you're coming from, and how that relates to, how that impacts how you relate to others.
Yeah, that makes sense to me. So Adrienne, can you tell me what are the key areas where culture can impact how we actually provide palliative care?
Well, for this question, Gaye and I were thinking we would just note some of the really broad areas where culture has a big impact in our palliative practice. One of the biggest areas, of course, would be family and social structure and dynamics. So how the family is organized, and this would apply both to, I think, Aboriginal and other culturally diverse groups. The organization of the family, the roles and responsibilities of the family, and particularly in palliative care, around decision-making. Who makes decisions and how are they made? And about the disclosure of bad news. So how do you do that within the family structure? A couple of the other areas where this has a big impact would be the perceptions of health and illness and dying. So the cultural perspectives and the spiritual perspectives. Of course, we're talking about spiritual as well on that, as well as values like life value orientation. So how this particular culture sees time, past, present, future orientations, whether they see things as cyclical or linear, that sort of thing. Another piece that comes into palliative care would be the perspectives of the locus of control. So whether a person feels that they have, from their cultural perspective, whether they feel that they have some control over what happens in their life, or how much do they feel that things just happen and you have to respond to what happens around you. And the other big part, which I'm sure most of the people who work in palliative care already are aware of, is communication styles and how we interact with each other. Things like personal space and conversational style and pacing and treatment of professionals, that sort of thing. So those are really broad areas I haven't given you any really interesting information about specific cultural groups, but these are the broad areas we need to keep in mind when we're thinking about cultural competency in a cross-cultural context.
Yeah, I think that what you've really identified is some key areas specific to hospice palliative care where we need to consider that the person might be from another culture and that we might need to do something a bit different. Mm-hmm. Great. Do you have anything to add to that, Gaye?
I think it was an excellent summary and certainly it sort of gets to many of the points that we've discussed and developed in our work. Just to accentuate, I think, the notion of communication styles and relationship building. And I think if we think about relationship building as a process, that's almost an iterative process, that each time we come into contact with an individual or family, we're hopefully deepening and broadening our relationship with them. And within those nexus, that relationship development process, there are nexus points, the beginning, the key decision-making points. And to recognize that because you don't know all of the various things that are affecting that family, that it may be very much an inconsistent and ever-evolving dynamic, that you can't assume that because a family sort of has it all together and seems to be well-organized and well-defined roles and responsibilities one day, that there aren't an accumulation of stressors in that day that then cause them to move to another place. So that relationship building causes that need to always assess as we're re-entering the relationship, sort of what's going on with the family. So not to sort of get to the point where you're making an initial assessment and that assessment isn't evolving along with the care relationship. And so that would be the only three areas that I would add to what Adrienne's already mapped out.
So, Gaye, what are some unique issues for the Aboriginal people?
I think some of the unique issues are the history of Aboriginal peoples in this country, and obviously that differs place to place and Aboriginal group to Aboriginal group, and particularly thinking about the effects of colonization, residential schools, the impacts on culture, on language, on location, residence, that sort of thing, and understanding that Aboriginal people live in all kinds of different settings, rural, remote, as well as urban locations, and that often affects the way in which they see the world and how they relate to it. And there's always jurisdictional sort of issues within the lives of Aboriginal people as it relates to care, that often there are federal and provincial, territorial responsibilities as well as emerging responsibilities with First Nation Métis governments. And the values and characteristics along many of the lines that Adrienne has mapped out do differ across Aboriginal groups, within Aboriginal groups, and between Aboriginal groups and others.
Adrienne, what are some unique issues for immigrants, refugees, or other culturally distinct groups?
As Gaye pointed out, I think, history and context and historical experience are so important, particularly for immigrants, refugees, and cultural groups. Just to distinguish between those, when we speak of immigrants, we're talking about people who have come to Canada usually by choice. They've chosen to come here and they're coming. They've applied, and they're usually accepted to come based on their professional skills or their education, that sort of thing. Whereas refugees, more often, don't come by choice. They're usually fleeing a difficult situation, either war or natural disasters or whatever, and they're often sponsored by the Canadian government or by church groups or by nonprofit groups. So they come in quite a different situation. Usually they don't have the language abilities that immigrants who come as independent immigrants are chosen for. So they have a lot more challenges to adapting to life in Canada. The things that would be different for these groups when they're here in Canada are the experience of immigration, and there's a whole bunch of things that happen to people through that experience, such as the loss that occurs when they leave things behind, their homes and their cultures and their friends behind, and come to a new country, and then the process of adaptation. And as we mentioned, often at the end of life, or when there's people are nearing the end of life, spirituality becomes more important, as well as the culture of their childhood or their where they came from becomes very important in terms of how they make meaning of what's happening to them. So people can go back to or often look back to where their birth culture to think about how to make meaning of the process of dying. And I just wanted to mention that what we're seeing here at the Royal Alec Hospital, and I'm sure this is similar across the country, is that the people that we have in palliative care are often the older immigrant groups that are now reaching their 70s and 80s. So the people that immigrated in the 50s and 60s and 70s, Italians, Portuguese, Ukrainians, those groups are among those that are reaching the elderly stage. Often the refugees and immigrants that we are seeing arriving in Canada today are younger aged. So I'm thinking that the majority of the people you'd be seeing in palliative care would be from the older immigrant groups. The only other thing I was going to mention that is important is the thing that we mentioned before about changing dynamics between generations, so that maybe if you're dealing with an elderly Italian person, they might have particular ways of seeing things and understanding things and wanting to do things, whereas maybe their children, who are often the decision makers or the caretakers, may see things differently.
Okay, thank you. Gaye, how do we implement culturally competent care into our practice for Aboriginal people?
One thing I think, Jackie, that we need to be thoughtful of is the wide-ranging diversity that needs to be understood and responded to in order to assure culturally competent care. So on one hand, we may have a group of Aboriginal people that are change-oriented, quite acculturated, aligned with mainstream society in many ways in terms of their values and lifestyles. And on the other hand, perhaps sort of subsistence-oriented people or more traditional people that are closer tied to their traditional land base that may have more traditional values. And we tend to get caught sometimes sort of thinking about the comparison between Aboriginal and mainstream society without somehow being able to see and really be very clear about the diversity which exists within the Aboriginal society. And so I think that's important, and to not assume that just because someone's older, they're necessarily more traditional, that we're seeing within Aboriginal populations a return often to more traditional beliefs and values among some of the younger people. And some of the older people, sometimes they've been involved with mainstream society for 2 or 3 generations and have become very much integrated into that way of thinking. And in the work that we've done in developing the curriculum around Aboriginal end-of-life and palliative care, we came to the understanding that the best approach is a relational approach. This means that the care team invests in developing effective and respectful and responsive relationships with individuals, families, and communities. And that's in order to hear their requirements, hear their priorities, and allow for those requirements and priorities to direct care as much as possible within the care setting. And we always know that we don't have all of the capability to respond that we'd like to have in any particular care setting, but to be able to do the best that we can and to be as responsive as we're able to respect the needs of the dying individual as well as the family that is involved in that whole process. And investing in further understanding the history, issues, challenges, values, communication styles, relationship features, including how a family sometimes may deal with conflict and particular impacts of what they see as trauma or what they see as a difficult situation, and other aspects of Aboriginal life, and that provides then the context for good working relationships. I see the investment in ongoing development of awareness and building skills and competencies as being sort of a lifelong practice and grounded, as Adrienne identified, in a very thorough self-awareness, that it's very difficult for us to work across the cultural relationship kind of, in quotes, divide without being really clear about where we're coming from as individuals. So to seek experience, to seek training, to seek advice and mentoring from individuals that are knowledgeable about these populations is certainly my word of advice for individuals interested in furthering their competence.
So would you suggest that as a nurse who may be going in for the first time with an Aboriginal family, that part of your assessment would then be to ask about their history, ask whether or not they've had experience with residential schools? Can you give me some practical ideas of how would you begin your assessment? How would you begin to gather the information you need so that you can be culturally competent?
First, I would suggest that it really depends on, again, the nature of the family, but I tend to believe that we need to develop some mutual trust and respect before we can move in with a whole battery of questions. And I recognize that that's sometimes difficult depending on the care context, but particularly a very traditional family may not respond well if all of a sudden they're faced with 10 or 20 questions that are very directive. So it's much better to try and invite the family to tell them as much as they're prepared to offer in any one setting, tell their story. Tell us about sort of what's going on in your family now. Tell us about where your family comes from, where do your relatives live, and to try and get a sense through more indirect questioning and a sense of really seeking to understand their family context without a series of very directed questions. And again, if you're working with more of an acculturated group, they would be more comfortable probably with a sort of an assessment instrument sort of approach.
Are there certain issues that we need to be aware of when working with Aboriginal people? Certain cultural beliefs or traditions that we should know about?
Well, certainly there are many different examples of some of the traditional beliefs, and to recognize that a First Nation person, for example, may or may not believe traditionally, that in one family you may well have a traditionalist who, for example, may believe in reincarnation, may believe in the role of the ancestors in welcoming or guiding the person into the spirit world. Within that belief system, often a strong connection to traditional land base and extended family. There may be the use of cleansing ceremonies such as sweat lodge or smudging or fasting, those kinds of things. But what's very important is not make an assumption that because someone comes from an Aboriginal background that their spiritual or religious beliefs tend along traditional lines, that you may just as easily have someone who is a very devout Christian or is engaged in another world religion such as Buddhism or the Baha'i faith. So it's important to seek to understand the individual beliefs as well, the diversity of beliefs within one family, which can sometimes be a source of conflict, especially around a situation at end of life.
As a healthcare provider, are there behaviors or things that we should not do when working with a traditional family? Can you give us suggestions of ways that we don't offend people with traditional beliefs?
Well, I think one of the things is to try and have as much time available as you can possibly have. So if there's an opportunity to sit with the family, to have tea, or to share food with the family, that's a very traditional way of creating community and creating respect. Often a family with that background really wants to know sort of who you are as an individual, and so they may ask you questions or provide openings for you to share a little bit about who you are as a person. They're interested in knowing whether you're a mother or a father, if you have children, how long you've been practicing nursing or medicine or another health profession, some of your interests are. And often the mainstream view of those things is that's personal information that somehow doesn't belong in a care setting. But often a traditional family will trust you because of who you are and what you bring as a whole person, not just because you have a particular professional designation. So as much as an individual, you can be open to sharing yourself, and the setting allows for taking some time to have some tea or break some bread and really have a conversation and share life stories. That can be a wonderful foundation.
Well, thank you. Adrienne, how do you implement culturally competent care into practice when we're working with immigrants and refugees?
Well, I think many of the things that Gaye talked about with the Aboriginal community are similar with immigrant and refugee populations. One of the things that we often suggest to people is when you're beginning the relationship, begin formally and carefully to gauge how these people would like to interact, and gently and calmly. And I know this is one of the things that the Pallium materials have really stressed, and they did it really nicely in the video clips that I saw that Gaye and company prepared. The other thing is building on what Gaye was saying about the personal. For many people from many cultures, but we don't want to stereotype, but for many, the personal relationship becomes first before a professional relationship. They don't want to see you just as a nurse or a physio or a physician, but first you're a person. So when you begin a conversation, it's not jumping right into the technicalities of the diagnosis and the treatment, but rather starting off with some time to open, just, how are you? How's your day? How's your family? Those kind of things. And exactly like Gaye said about Aboriginal communities, also, if as appropriate and if appropriate, sharing a bit about yourself so that you're two human beings interacting rather than a professional and a patient, first off. Another thing that, and I completely agree with Gaye on this, it applies to other cultural groups as well, is asking only relevant questions about culture. It's sort of impossible to sit down with someone and say, okay, tell me about your culture, and then go through a whole list of questions, because most of us can't do that, do sort of a 5-minute wrap-up explanation of our own culture. Rather, these things are sort of revealed through time and as they become appropriate. So when you're discussing something specific about care, or then is the time to say, well, is there anything that we should know that would help us in how we provide this for you? Or as they come up, ask the questions. The other thing is to ask about preferences or how they would like to do the decision making. Who are the people in the family that should be involved in that? So not making the assumption of individual autonomy, which is sort of seems to be the way our mainstream system operates, but leaving it more open to the family to decide how they want to do that, as well as their preferences about disclosure of information. So who in the family should be involved when new information is being shared. The other thing I would just say is about people's interpretation of their illness and trying to understand how they view this illness, whether they see it, for many people from different cultural backgrounds, and probably even for mainstream people from your basic middle-class white Christian background, a lot of people see illness as a result of something, not just from a medical model, but that it maybe is the result of something I did. And so trying to understand where people are coming from in terms of how they see their illness as part of their life, and then seeing if there's ways of integrating what they see as the appropriate response to that into their treatment. That's rather vague, but I'm hoping you can understand the general gist of what I'm saying in terms of how to approach people that have different perspectives on health and illness and dying.
So can you give me examples of questions? If you particularly wanted to talk to a family about advanced care planning, so you're wanting to talk to them about planning possibly for a home death or their decision of how long they want to provide care at home if the person's at home, and you want to specifically talk about that area of death and dying, what would be some examples of questions that you could think of that you could ask that would be acceptable?
For an example, we did a small study here at the Royal Alec Hospital that included 3 groups. We had intensive interviews with Italians, Chinese, and Sikhs, and asked them about the death and dying process and how they felt about that around disclosure of poor prognosis. It was really interesting that, say, the Italians, the majority did not want to disclose the complete bad news to the patient. They would rather have the main family learn about that first, and then they find out how they want to disclose that, if they want to disclose that to the patient. And that was related to their thinking that patients lose hope when they find out that there's a negative diagnosis. In the Chinese community, however, we found that people were more often, and these are some people within those communities, remembering always that we don't want to stereotype, that within the Chinese, we found that many of them didn't want to discuss death and dying or negative prognosis in a really open way, because when you talk about that out loud, that's more likely for that thing to happen. So that has a real impact on whether you're going to create a personal directive. Why would you want to sit down and discuss all the negative possible things that could happen to you in the future? Well, if I'm brain dead and on life support, this is what I'd like to have happen to me. Why would you do that if that's more likely to make that happen? So things like that come in. So practically, how do you deal with that? In terms of disclosure and decision-making in the family, if there's a way of asking the patient, because we don't want to make the assumption that the patient doesn't want to directly talk with the care provider about it. If there's a way of asking them, well, would you prefer me to discuss this more with your son, or whoever it is that seems to be the major decision-maker in the family, and that they say, yeah, you can talk to them about it. Then take your cues from them about who to speak with more in greater detail about the issues.
I found that really challenging, actually. I was working with people in the home when the patient or the client actually wasn't told or didn't seem to be aware of what was happening. I think that's very challenging as a healthcare provider because it's different than our beliefs.
Right. Especially the mainstream system, which is set up in such a way that it's all almost completely based on personal autonomy and decision-making. almost as a legal requirement, physicians are required to speak first with the patient about the diagnosis. So how do you deal with that as a care professional?
Right.
It's a big challenge.
Any suggestions?
I haven't got the complete answer for you, unfortunately. But as I was saying, I think the best way to cope with it is sort of a negotiated response, sort of asking the patient, what would you prefer? Who would you like me to talk with? Or in that way getting at how much they want to know and how much they'd like you to discuss it with other family members. That's probably almost across the board in most other cultures, and I think probably for most mainstream Canadians in a few generations back, we were much more collectively based in our decision-making, and our identity and how we interacted in the world was much more based on family and community rather than the individualism that's sort of dominant today. And that's almost across the board in cultures from around the world. So I think probably in our care, involving the family is so important, and making sure that they're involved in the way they want to be.
Okay. We do have a couple of questions from the participants' registration form. So let's deal with those first, and then I think we'll open it up for questions from the audience. The first question was from Andrea Mowry from Kelowna, and she actually wanted to know about resources, websites, or books.
The Pallium Project has developed a course planning manual and courseware entitled Responsive Hospice Palliative Care with Aboriginal Clients in Rural and Remote Settings. And this is courseware that if you were to deliver all of it would probably take 6 days or so. So what we tend to do is pick and choose bits and pieces depending on how much time we have available. And that's supported by a series of PowerPoints and 14 DVD segments, as Adrienne had suggested. And this is licensed courseware, and right now we're in the process of training trainers in this courseware across the country. And we now have 25 trainers that have been trained in Vancouver in September. So we do have some BC-based trainers. So it's not courseware that's generally available, although we can offer it up for review, and we certainly could make some arrangements to train trainers in this courseware if that was to be helpful. And we could also make the list of resources that we use available. We found that when we did the literature review, that on the basis of which some of this work was done about 3 years ago, there was very, very little in the literature around Aboriginal views, and particularly around the cultural competency and the degree of sort of depth of understanding that we need around what that means in Aboriginal communities. Aboriginal Nurses Association of Canada is also a resource and has done a number of publications that are not considered academic literature, but they're certainly in the grey literature category. So we could make a list of that available, Jackie, for distribution.
That would be great if between Adrienne and you, if you could make up a list, and if we'll forward it to the Pallium office and then have it sent out to the participants of this teleconference, that would be great. The next question is actually for you, Gaye. It's from Regina Breaker in Nanaimo. She wanted to know, how would you support Aboriginal patients in a palliative care unit?
So we're talking probably a hospice or a hospital-based palliative care unit?
Yes.
And my response to that would be that one of the things that is very helpful is try and make sure that your organizational context and policy and procedures allows for visitation by the family. That sometimes when we're in an institutional setting, the numbers of visitors that want to come and the number that sometimes want to be available around the bed sort of at one given time can be a problem in an institutional environment. So that's just an example of some of the policy issues. An Aboriginal family also may want to have traditional ceremonies in a hospital setting, and certainly the Royal Alec, where Adrienne works, has made special arrangements for physical space that's ventilated in such a way that sweetgrass ceremonies and other ceremonies can occur. So to find out if the family does practice traditional practice and whether or not any of that would be, in their view, integrated into end-of-life care. Often we were talking about sort of what are the magic questions. And I find that often to start, before we start asking questions, with a statement of intention that lets the individual know that you understand that they come from a cultural background that may have unique requirements, and that it's your intention to do whatever you can to respond to those. And that will often give the person permission to start bringing forward some of the special concerns that they weren't sure whether or not these concerns or these requests had a place in an institutional environment. So to make that commitment, and it's also very honest, and honesty is deeply valued in Aboriginal culture, very honest to say there are some constraints or challenges we may run up against in terms of what's physically, possible within our environment, or what's required by the ethics as it's practiced in that environment, or the policy considerations. So, for example, if there's a very clear policy that the patient absolutely has to know about everything to do with their diagnosis and illness, to try and move around that policy and still be respectful of that as well as the family's wishes. The family at some level needs to know that there is an issue to be navigated and what the reality of the legal requirements are, along with responding to their culturally based requirements. So those are just some thoughts that I could come up with. Jackie, thank you.
Oh, that was great. I like the suggestion to give them your intention of providing support for them. What you said, I think that was a good idea. It's a good idea.
This is a colleague of Andrea's, Sandy Pulfer. How would you respond to the comment that people are much more alike across cultures than they are within their own cultures? I would like to hear the speaker's comment on that. Thank you.
Basically, what we understand is that physiologically, on the inside, we're all the same, right? So there's many sort of similarities in our physiological makeup, our physical makeup as human beings. And that on a spiritual level, we're all human beings. We have a connection, human to human. And I remember having a spiritual experience with sort of a visitation of my Cree grandmother, and she sort of turned into this rainbow of every color in the universe. And I said, "So are you still Cree in the afterlife?" And she sort of looked at me and responded and said, "I'm everything and I'm nothing. It doesn't matter here." So on a spiritual level, we're human beings. We have that connection of humanity, and that's why it's important to get beyond the differences to make that humanity, that connection between, sort of human to human. And I noticed traveling the world in my shiftless 20s that the admiration, for example, that you can express for the beauty of a child, for example, the parent picks up on that even if you have no language in common. The fact that you gesture and let them know by body language that you think their child is beautiful. What differs is then how you move into a relationship. I remember traveling in Thailand, and as an old public health nurse, I always wanted to reach out and touch a baby. And in Thailand, if you touch a child's head with your hand as a stranger, that seemed to be a major insult to the family and injurious to the child at some level. So the way in which spoken language and what we say and how we say it and our body language is interpreted across culture is, I think, where the complexity occurs, that as we intend to make connection, none of us intend to be racist, none of us intend to be disrespectful of someone, but it sometimes happens because we just don't know any better. So I often find that in relationships, if we can put that sort of disclaimer out that basically says, I hope to and intend to be able to connect and communicate with you human being to human being, and let's try and deal with the difficulties of getting that communication link established by sort of respectful and gentle communication and good feedback, and give people permission to let you know when things aren't working well. So I think it's the social context, the communication styles, all of that can be different, that somehow then gets in the way of us connecting in our sameness.
I think Gaye sort of got the real core of it. I think that's the balancing or juggling act that we're doing, in that we want to recognize difference and respect difference, but at the same time understand the similarities and commonalities across around the globe. We all have multiple identities, and in some way you can identify and connect with other people based on any one of those. For example, as a woman, I can maybe connect with another woman from a culture that's completely different than mine, just because we're women and many of our experiences are the same as women. Or growing up on a farm. Maybe you grew up on a farm and somebody else comes from a farming background in another country. There's connections there in your identity as rural farmers. at the same time, and those are the things that can bring us together, those similarities, but at the same time, we need to recognize and respect and not deny difference across cultures. Recently, I was in a workshop where a woman from the Dominican Republic was saying how offended she was when someone said to her, "Oh, you know, you're such a good friend. I don't even see you as black." And she felt very offended by that because it was such a denial of her, a core part of her identity being from the Dominican Republic. So I guess that's the tricky thing that we're trying to navigate in this, is finding the places where we can connect with each other, and then around the things that are different, learning how to grow to understand and respect each other better around those differences.
I would like to share with you the take-home message from the speakers, which are: the challenge for healthcare providers is to understand, respect, and facilitate our patients' culturally based perspectives and practices, but at the same time not to stereotype them within categories that erase their unique individuality. The next one is, like spiritual faith, people's cultural beliefs and practices often become more important to them as they make meaning of the dying process. And finally, appropriately demonstrating respect and caring are the foundation of establishing a culturally competent relationship with our patients. Knowledge of specific cultural beliefs and practices are secondary. I'd like to thank Gaye and Adrienne for joining us today and sharing with us ways to become culturally competent and ways to implement cultural competence into our practice.
This has been a Pallium Project Professional Development Podcast. For more information on the Pallium Project, including written transcripts of this session, please visit www.pallium.ca. PALLIUM.